So I'd like to formally welcome all who are attending live, and if you're watching the recording, a very warm welcome to you as well. And of course, welcome indeed to Dr. Chris Arden, who is presenting this webinar session this evening, Increasing Awareness of Heart Valve Disease in Primary Care. And heart valve disease is increasing in prevalence and is associated with a negative impact on a patient's quality of life and life expectancy. Primary care plays an important role in identifying patients with heart valve disease and, when appropriate, referring them for further evaluation and intervention as required. And this presentation will cover the etiology of heart valve disease together with potential symptoms, appropriate investigations, and indications for referral. So the expected learning outcomes: to understand the epidemiology and increasing prevalence of heart valve disease, also the symptoms associated with heart valve disease. Appropriate investigations will be looked at, when to consider referral, and potential intervention options for patients with heart valve disease. Dr. Chris Arden is GP partner at Park and St Francis Surgery, Chandler's Ford. He's experienced both in general practice and in community cardiac clinics assessing and managing patients with heart failure, and is a GP with special interest cardiology, and is on the board of trustees now for the charity Heart Valve Voice, who are supporting this session this evening. I'll hand over now to Chris, and before I do, just a reminder, any questions or comments, please use the chat function, and for questions, the Q&A tab, and we'll do our best to deal with any queries or questions that you might have. Type them into the Q&A tab when they come to mind, so that you're not leaving them till the end, and we should have an opportunity to cover questions. So I'll hand over now to Chris. Thank you so much, Chris, for giving this presentation and giving up some of your valuable time to talk to colleagues this evening. Thank you.
Great. Thanks very much indeed, Simon, and thanks very much indeed to everyone for coming along and joining us this evening. This is all on behalf, really, of just trying to increase awareness, not just in within the medical profession, but obviously public generally, around the issues relating to heart valve disease, particularly in terms of trying to be a little bit more proactive in terms of identifying patients with valvular heart disease, because the interventions and treatments are so effective. Heart Valve Voice was originally set up about 5-6 years ago, and is really a collaboration between patients, cardiologists, cardiac surgeons, GPs, and relevant cardiac patient society, all with an interest in terms of trying to raise awareness around valvular heart disease. What I'm going to look at this evening is really, as Simon mentioned, looking at some of the background in terms of the epidemiology and etiology of mitral and aortic valve disease. I'm going to focus primarily on left-sided valve disease, because that's the one that's probably most clinically relevant to us in primary and secondary care. And certainly when it comes to intervention, the vast majority of patients are going to get interventions for either mitral or aortic valve disease. So although we'll briefly cover right-sided valve disease, the majority of the talk will be around left-sided disease, because that's the most relevant and also the most amenable to intervention. The most important screening tool in many respects is auscultation. So that obviously starts with us in primary care. So either doing that opportunistically or being alert and aware to potential symptoms that might represent underlying valvular heart disease. We then need to think about appropriate investigations, those that we can initiate in primary care within our setting, within the surgeries. And obviously the vast majority of patients will probably need some form of imaging, and the most accessible of that is echocardiography. So I'll go through some of that and the images and the criteria that we look for in terms of evaluating the severity of valvular heart disease. Most importantly, in many respects, is looking at timing of interventions and what potential interventions are available now to our patients. And I'll try and wrap it up with a case study, hopefully, to bring it all together at the end. Just starting off with as a question for you all, just as a warm-up, just wondered, in terms of our patients that we see in general practice over 75, roughly how many do you think would be suffering from any form of valvular heart disease, from mild through to severe? Is it roughly about 5%, 8%? 13% or as high as sort of 1 in 5, 20%. If you don't mind just having a quick poll.
For this poll, we'll just get you to type into the chat, type in the letter that refers to your selection, because it's not in our software just now. So let's see, we'll be able to see in the chat box. Fantastic. So I'll give you another 10 seconds. So we're split equally at the moment between C and D.
C and D. Okay, excellent, excellent. It's actually C, so about 1 in 3, sort of 1 in 7 or 8 of our patients will have some form of valvular heart disease. And obviously that number is going to increase over time with the sort of changing sort of demographics. So a bit like atrial fibrillation and hypertension, this is something that we really do need to be increasingly vigilant about and aware of. Symptoms of valve disease may not present again until the condition becomes relatively severe. So again, the earlier we can pick it up, the earlier we can think about potential sort of intervention, whether those are sort of medical or later on sort of surgical intervention. Auscultation is the critical first step in diagnosing valvular heart disease. And again, just always need to be aware that even a faint murmur may be present even with significant valvular disease, particularly in the context of LV systolic impairment. So clinical examination, particularly auscultation, is the first step and the most important step in terms of establishing the diagnosis. So we must be prepared to sort of examine our patients as well as taking their pulse in terms of thinking about arrhythmias and atrial fibrillation. It's really, really important that we're sort of comfortable and think about auscultation and maybe being opportunistic. So in sort of populations with a higher prevalence of valvular heart disease, always having a listen just in case you may pick up something that's almost sort of incidental but may well become relevant further down the line. So we just need to be much more proactive in terms of listening to our patients' chests. Typical murmurs, again, I'm sure you're all very familiar with this. Obviously, you've got the sort of systolic and diastolic murmurs. First heart sound is represented by the closure of the mitral and the tricuspid valves, and the second heart sound by the closure of the aortic and the pulmonary valves. So typical systolic murmurs, obviously ones we're most concerned about, around aortic stenosis, which is the typical crescendo, decrescendo type murmur. Mitral regurgitation, again, there's a lot of it about, tends to be slightly more pronounced in the early part of systole. Aortic regurgitation, looking at sort of diastolic murmurs, again, usually in the early part of diastole, as with mitral stenosis tends to be in the latter part of diastole. So I just listen to give you a few examples of just starting off with sort of normal heart sounds. So you've got the classic lub-dub. The lub is the first heart sound, which is the mitral and the tricuspid closing. And then the second is the pulmonary and the aortic valve closing, which is the second heart sound. Now the aortic stenosis. So you've got that typical sort of about a harsh crescendo, decrescendo type murmur. It's into mitral regurgitation. Softer, not quite as intense or harsh, and certainly more prolonged, and tends to be more pronounced in early systole. Pulmonary stenosis. Again, not quite as pronounced or harsh as the aortic murmurs. And tricuspid regurgitation. So again, that's systolic, best heard at the sort of left parasternal edge and about the 4th or 5th intercostal space. So those are the sort of typical murmurs that we'll be looking for when we're examining our patients. Focusing on particular valvular disease, I'm going to go through sort of mitral disease first of all, looking at mitral regurgitation and then mitral stenosis. And after that, I'll look at aortic regurgitation and then finally aortic stenosis. Looking at mitral regurgitation first, in terms of mechanisms and etiology, obviously that can involve a number of areas in terms of sort of the valve apparatus. So you've got the leaflets themselves, so you can have prolapse, or rheumatic thickening of the leaflets, or endocarditis, where you get active destruction of the leaflets. You can have issues with the chordae, so the apparatus below the valve, so you can get degeneration or trauma, or again, infective endocarditis that can cause damage to the chordae. You can get annular calcification, so the leaflets and the valves themselves may be functioning normally, but you get dilatation of either the LV or the left atrium, and you get sort of functional regurgitation. Papillary muscles, again, you can see damage in coronary artery disease or ischemia, hypertrophic cardiomyopathy or infiltrative disorders, or lastly, trauma. So there's a number of different mechanisms that can contribute to mitral regurgitation, either in isolation or more commonly in combination. In terms of the pathophysiology and the hemodynamic consequences of mitral regurgitation, initially, certainly while the patient is relatively asymptomatic or has only mild symptoms, they may well get compensatory LV dilatation, all the while maintaining cardiac output. Over time, though, due to the increasing mitral regurgitation, you get decompensation with increasing left ventricular wall tension, which starts to lead towards impaired LV systolic function. Around about this time, you'll also get LV dilatation, which tends to exacerbate the mitral regurgitation because you get annular dilatation, so you get drawing apart of the mitral valve leaflets, and that again just exacerbates the underlying incompetence in the valve. In terms of what's happening within the left atrium, you get LA dilatation and remodeling, you get increasing LA pressures with pulmonary hypertension, and with the left atrial remodeling, you get significant increase in atrial dysrhythmias. Most important of those is atrial fibrillation. This is the typical picture that you see on echo with mitral regurgitation. So in this situation, you see significant central regurgitation. The posterior mitral valve leaflet appears to be relatively fixed. Significant dilatation of both the left atrium and the left ventricle. So again, you've got a degree of annular dilatation that's contributing to this. So again, as with a lot of cases, it tends to be multifactorial, but this is these sort of severe mitral regurgitation. So this is what we typically see on echocardiography. Again, just reminding ourselves, where's the best place to hear sign of mitral regurgitation? It's in the mid-clavicular line in the fifth intercostal space. So again, relatively soft, often pansystolic. The more severe the mitral regurgitation, then it becomes pansystolic. Probably a little bit more pronounced early in systole, but certainly when you get moderate severe, it'll be across the whole of systole. So symptoms, so how may patients present to us in primary care? And again, this is where we just need to be, keep an open mind, because we do see a lot of patients, obviously in general practice, presenting with these symptoms such as dyspnea, reduced exercise tolerance, fatigue, tiredness, orthopnea. In more severe cases with pulmonary hypertension, you may get signs of right-sided failure or systemic embolization. Certainly if they've got atrial fibrillation, again, that significantly increases their stroke risk. And again, they may well have a significant amount of left atrial remodeling and dilatation, which again will be exacerbating the underlying mitral regurgitation. So as cause and effect, really, the mitral regurgitation may well lead to these complications, and then it becomes a sort of downward spiral. But it's just really pertinent for us to be aware of symptoms that patients may present with. In terms of what we might see on investigations that we do in the practice, so ECG may well show signs of potential left atrial enlargement, although that's very, very non-specific finding on an ECG. The more important things to look out for are sort of atrial arrhythmias and atrial fibrillation, just because of the increase in stroke risk. There may be signs of LVH, particularly in the sort of strain, because the heart's having to work harder in terms of the workload, so you may get signs of LVH. Chest X-ray, you may see signs of increased pulmonary vascularity, increased cardiac size and cardiac megaly, or even signs of heart failure. And again, if there's significant calcium around the mitral annulus or the mitral valves, that may well be evident on X-ray. The key test, though, investigation-wise, is echocardiography. So I think if you see any patient with signs or symptoms suggestive of mitral regurgitation, then I'd have no hesitation at all in terms of organising, requesting an echocardiogram. Obviously, you'd also request an ECG, just looking out for atrial fibrillation. So the echo, again, looking at potential etiology, so looking at the leaflet function, are there signs of cordial papillary muscle rupture? Are there signs of mitral valve prolapse, or in acute situations, possibly even endocarditis? Again, echo is very useful in terms of trying to quantify the severity of the mitral regurgitation, as well as, very importantly, looking at the LV to see if there's any signs of early systolic impairment or dilatation. When we're thinking in terms of sort of treatment, so we've made an assessment, we've got the echo, they've got moderate, severe mitral regurgitation. We then need to be thinking in terms of how to manage this patient, both in the short and the longer term. Ultimately, if the patient is suitable for surgery and intervention, the only effective treatment for patients with severe mitral regurgitation ultimately is valve repair or replacement. Optimal timing really is determined as much by symptoms, although sometimes younger patients can have really quite pronounced mitral regurgitation and have quite a significant amount of functional reserve. So actually they don't become symptomatic until really quite late on. So again, just need to be mindful of that. The functional state of the ventricle is important, so any signs of reduced ejection fraction or LV systolic impairment, or any signs of LV dilatation, again, would be an indication to think about intervention. Looking at the feasibility of either replacement or valve repair. Certainly other comorbidities, so atrial fibrillation, established pulmonary hypertension, will obviously have a bearing in terms of assessing the patient's risk of intervention and their potential long-term benefits, as well as, most importantly, thinking about the expectations and patient sort of preference. Timing is absolutely critical again. Certainly surgery reduces morbidity and mortality from severe MR, but exposes the patient obviously to the risk of open surgery and having a prosthetic valve. Surgery should ideally be performed before the onset of severe symptoms or the development of LV systolic dysfunction. Guideline recommendations, certainly surgery should be recommended in patients who are symptomatic or asymptomatic with any LV dysfunction or dilatation. Signs of pulmonary hypertension, so they've got increased left atrial pressures and thereby pulmonary pressures, or the valves are amenable to repair. So this is just a typical echo of a severely impaired left ventricle, which is also dilated. So this is obviously something you don't want to see when you're putting patients forward for surgery, because the outcome, the risk of perioperative risk is significantly high, and the chances of them potentially gaining benefit long term is again significantly reduced. So what are the pros and cons of replacement versus repair? So valve replacement obviously is a far more invasive procedure, either a tissue or more commonly a mechanical prosthetic valve. Not insignificant mortality related to the procedure itself, so up to 7%, and for patients will require anticoagulation long term. Patients have valve repair, far less invasive in that sense in terms of the actual perioperative risk, and mortality is probably half that of valve replacement. Patients, because they still have the native valve in situ, don't require anticoagulation unless there's another indication such as atrial fibrillation. And there's preservation of left ventricular and ejection fraction. Valve repair is usually preferable and certainly is feasible in 70 to 90% of patients. Any questions on MR before I go on to mitral stenosis, Simon?
At the moment, no. I think we're all good. Thank you very much for asking. Great stuff.
Everyone's still there?
Yes.
Okay.
Yeah, they're all there.
Just
Great
checking.
stuff.
Okay. Okay. So I'll go on to mitral stenosis now. I was just looking at the other issue with the mitral valve. Actually, interestingly, we don't see sort of significant severe mitral stenosis as much these days, obviously because 99% of it is rheumatic fever in origin, and thankfully we don't see that as commonly now. Certainly in sort of elderly patients or those who maybe have lived abroad where the rheumatic fever is still endemic, then it's certainly something to consider in terms of patients who might be presenting with symptoms of possible mitral stenosis. In this situation, you get significant scarring and fusion of the valve leaflets and the apparatus with restricted valve orifice. Pure or predominant mitral stenosis occurs in approximately 40% of all patients with rheumatic heart disease, and interestingly, 2/3 of all patients with mitral stenosis are female. In terms of the pathophysiology, the normal mitral valve area is between 4 to 6 centimeters squared. Generally, patients don't develop symptoms until they develop at least moderate, if not severe, mitral stenosis. And this can be over a relatively long sort of time frame. So initially, the disease can be very, very sort of indolent and relatively asymptomatic. And certainly, we do a lot of echoes, and you see a lot of annular mitral calcification, but actually you've got relatively well preserved leaflet motion, and those patients generally won't run into problems in terms of actually having functional stenosis. It's really the rheumatic fever that is far more progressive in that sense. In terms of symptoms that patients may present with, again, very similar to mitral regurgitation, so fatigue, reduced exercise tolerance, palpitations, again, similar mechanism at play in terms of change of the left atrial hemodynamics, and increasing left atrial pressures leads to sort of more stress within the left atrium, remodeling and dilatation, and therefore provides the substrate for potential atrial arrhythmias. And obviously, again, I reiterate the important one there is atrial fibrillation. Patients may present with cough due to sort of pulmonary congestion or typical shortness of breath, so signs of left-sided failure, orthopnea, PND, or even right-sided failure due to pulmonary hypertension. So again, patients may well present, their initial presentation might be with complications of mitral stenosis, such as atrial fibrillation or systemic embolism. And again, symptoms certainly be worsened by conditions that increase cardiac output. Natural history of mitral stenosis, it is progressive, it's a lifelong disease, but actually is usually slow and relatively stable in the early years, and the patient may well be relatively asymptomatic. Progressive acceleration in the latter years, but overall there's estimated to be probably about 20 to 40 year latency from having rheumatic fever to symptom onset, and then an additional 10 years before disabling symptoms. But obviously you're hoping that by that stage the patient has been counselled with a view to appropriate intervention. Complications of mitral stenosis, so atrial arrhythmias and fibrillation, systemic embolism, risk of embolism as it related to age, particularly the presence of atrial fibrillation, and in this setting, the risk of stroke has increased at least 16-fold in patients with atrial fibrillation, mitral stenosis. So this may not be part of your sort of CHADS VASC assessment in terms of whether these patients would warrant anticoagulation. I suspect the majority of them probably would have other risk factors that would would mean that they're sort of eligible for anticoagulation, but it's always worth thinking about valve disease when we're assessing patients' stroke risk with atrial fibrillation. And in mitral stenosis, that is very, very high indeed, even in the absence of any other risk factors. Patients may well present with congestive heart failure. So again, they've got some signs of breathlessness and congestion, pulmonary infarcts, results of severe congestive heart failure or hemoptysis due to pulmonary hypertension. These patients are at significant risk of endocarditis and pulmonary infections. Diagnosis, again, clinical suspicion, index of suspicion, examination obviously is absolutely key in auscultation. Diastolic murmurs are much harder to hear than the traditional sort of systolic, ejection systolic aortic or mitral murmurs. So the patient is symptomatic and you think the sort of index of suspicion of a murmur, then certainly echo would be the investigation of choice. Certainly we use echo to assess the hemodynamic severity, looking at the pressure gradient across the valve, estimating the valve area, and seeing if there's any signs of increased right-sided pressures in pulmonary artery, pulmonary hypertension. Assessment of valve morphology is important to see whether or not this may well be amenable to percutaneous valvuloplasty or repair. Looking as well to see if there's concomitant valvular lesions. So patients with rheumatic fever also have a high incidence of tricuspid stenosis and right-sided valvular lesions. So need to reevaluate patients with no mitral stenosis with changing signs and symptoms, and there should be a sort of regular surveillance program for patients with moderate to severe mitral stenosis, because we know at some stage they are going to become symptomatic, and obviously that would then be a mandate for intervention. So what are the treatment options in mitral stenosis? So we've got medical therapy, obviously relieving symptoms of congestion, so diuretics, the signs of left or right heart failure. If they've got atrial fibrillation, then looking at rate control, so beta blockers, calcium channel blockers, or in combination with digoxin. Very, very importantly, as I mentioned earlier, anticoagulation in atrial fibrillation is absolutely essential. In terms of whether you can use a DOAC or warfarin, certainly patients with mild to moderate mitral stenosis, most of us would still be comfortable to using a DOAC. A lot of patients do have annular or sort of basal leaflet calcification, but actually quite good mitral valve function. Again, I wouldn't have any hesitation in using a DOAC in that setting. Patients with more severe mitral stenosis, certainly they should be offered warfarin in preference to a DOAC, as one of the sort of licensing contraindications is severe mitral stenosis. They should be offered warfarin as anticoagulation. So looking at in terms of intervention, balloon valvuloplasty is certainly an effective long-term treatment and less invasive than open sort of surgery. Surgical options, so either mitral commissurotomy or mitral valve replacement, which can either be mechanical or bioprosthetic. Again, if it's mechanical, then obviously they need to stay on lifelong warfarin. Any questions with regards to mitral disease before we go on to aortic disease?
One question.
Sure.
You referenced mitral stenosis cases, 2/3 are in women.
Yes.
Is that relating to rheumatic valve disease or all cases of?
No, rheumatic fever and that's related to rheumatic valve disease.
And we're not sure why such a difference?
No, I don't know what the sort of pathophysiology of that is, but certainly it's much more prevalent in females.
Okay, and just a question, I guess we might come to it later about, there used to be all this dental prophylaxis for rheumatic valve disease. Do you want to deal with that later, or is that worth touching on now?
Yeah, no, that's a very good question, and there was a lot of debate a good few years ago now when NICE came out with some guidance basically recommending that there wasn't really a role for antibiotic prophylaxis. I think looking at other guidance, if you look at the ESC guidance or the American guidance, they would certainly recommend antibiotic prophylaxis in patients who've had any intervention for their valves, whether it be replacement or repair. And I think certainly the vast majority of cardiologists would be more comfortable giving antibiotic prophylaxis in patients with severe mitral stenosis. Patients with just a little bit of annular calcification, a functionally normal valve, the risk of endocarditis and infection is relatively low. But certainly moderate severe native valve stenosis, or anyone who's had a valve repair or replacement, they really should be getting antibiotic prophylaxis for sort of invasive procedures or dental procedures.
Okay, great. A question from Ronnie. Are DOACs safe in valvular disease?
Yes, yeah, no, good question. And certainly initially there was a lot of debate and probably a bit of confusion really as to how we define sort of non-valvular atrial fibrillation. It's now sort of very, very clearly defined as only patients who have severe mitral stenosis or anyone who's got a metallic heart valve. So if they've had any valve replacement with metalwork, then they have to have warfarin as their anticoagulant of choice. They shouldn't ever be on a DOAC. In terms of patients who've had tissue valves or valve repairs, again, that wouldn't be a contraindication to a DOAC. It's the mechanical valves, and obviously the majority of those tend to be aortic, although occasionally you still do see mitral metallic valves put in for either regurgitation or stenosis. So those patients would have to be on warfarin lifelong.
Okay, thank you.
Okay.
Yeah, and then the other follow-up question was, in terms of grading, when we're listening to a murmur, what is any clues or tips for us non-specialists to do with grading?
I wouldn't get too hung up on it really. I think it's a sort of, if you hear a murmur, I would just get an echo. I think we can be a bit too cute and try and be a bit too fancy. I mean, fortunately, and obviously locally, I know there are issues with access to echo, sort of, in other parts of the country, but access is much better than it used to be. I think if you're in doubt, particularly symptoms, and the nature and the character and severity of the murmur, as we mentioned earlier, it doesn't necessarily always correlate to the severity of the underlying valvular lesion. So I think if in doubt, I would get an echo.
Great. Thank you very much for that.
Okay. Thanks. So I'll go on to aortic valve disease now, focusing primarily on aortic regurgitation and then lastly aortic stenosis. Aortic regurgitation, so again looking at the sort of etiology or the sort of pathophysiology, can again be related to the actual valves themselves. So congenital, particularly bicuspid valves, so anything that's going to affect the valve function and leaflets. Patients with bicuspid valves do have much more stress over the valve and they don't function as well as the tri-leaflet valves, so they're certainly more prone to sort of incompetence and stenosis. So these patients tend to get a lot more sort of thickening, calcification of the valve with reduced valve mobility, which might lead them to getting atrial regurgitation. And certainly they do need sort of follow-up because obviously they have a higher risk of developing aortic stenosis. So aortopathies, obviously sort of Marfan's or Collinger disorders, cystic medial necrosis, they can also cause dilatation and change in the sort of proximal aorta morphology. So it isn't necessarily a primary valve disorder, but certainly can predispose to valve dysfunction and regurgitation. So acquired, again, we mentioned earlier about rheumatic heart disease, so dilated aorta, such as in hypertension, or connective tissue disorders. Again, you can get significant aortopathies and dilation of the proximal aorta. Acute aortic incompetence, such as aortic dissection, infective carditis, or trauma. So these are the typical features you see in aortic regurgitation. So this is just in a patient with severe aortic regurgitation in the three-chamber view. So again, and you can just see the sort of, can't really make out the left ventricle particularly well, but it appears to be mildly dilated, although the function looks relatively well preserved at this stage. In terms of symptoms, so exactly like the mitral lesions, patients typically present with dyspnea, orthopnea, paroxysmal nocturnal dyspnea. They may well be developing sort of chest pain, interestingly nocturnal angina due to reduced diastolic aortic pressure and increased left ventricular end diastolic pressure, reducing coronary artery diastolic flow. And with extreme reductions in diastolic pressures, you may see an angina or angina equivalent symptoms. In terms of the natural history of aortic regurgitation, if they're completely asymptomatic and have a normal LV, so good LV function, no dilatation, the risk of progression is probably less than 6% a year. If they're progressing to the risk of progressing to asymptomatic LV dysfunction is probably less than 3.5% a year, and the risk of sudden death actually is very, very small, less than 0.2% a year. If, however, they're asymptomatic but they've got abnormal LV function, then there's significant progression to cardiac symptoms of about 25% a year. So LV function, again, when you're assessing patients with aortic regurgitation, is absolutely key in terms of risk stratifying them. And as I'll come on to later, has a significant bearing in terms of the sort of timing of intervention or surgery. If the patients are symptomatic, then they do have a very, very poor prognosis indeed. And looking at real hard endpoints such as mortality, it's approximately 10% mortality per year. So patients with aortic regurgitation and symptoms, we really should be fast tracking through the system to be thinking about intervention if that's appropriate for that individual patient. So we can think about medical treatment in terms of trying to offset and mitigate some of the symptoms, but when we're thinking about prognostically important interventions, surgery is absolutely key, and timing again is very, very important before you get LV dysfunction and particularly LV dilatation, which is a poor prognostic sign in this setting. And again, surgery is just by open conventional surgery with valve replacement. And again, it could be either mechanical or bioprosthetic, depending on the age and the patient preference and the patient sort of profile. So coming on to the final stage of the talk, which is aortic stenosis, and I'll spend a little bit more time on this because obviously things have changed in terms of intervention-wise. So I think it's worthwhile spending a little bit of time looking at that. And also just being mindful of the fact that actually we're going to be seeing a lot more patients with aortic stenosis in the coming years, driven primarily by the changing demographics and an increasing elderly population. The greatest risk factor for getting essentially any form of valve disease is degenerative valve disease, which is age-related. So it's something I think it is worth spending a good little bit of time on, but particularly at the end because we're looking at the different options available in terms of intervention. So again, just quick poll, Simon, if that's okay. So just a rough idea. So just looking at aortic stenosis now in terms of our patients in general practice over 75, how many do you believe may have or suffer with aortic stenosis? 1 in 100, 1%, 1 in 20, so 1 in 8 or 1 in 5?
Okay, good. So the poll is live on the screen. So hopefully you can see that and you can cast your vote using your mouse. If you're maybe joining via a smartphone, you might not see the voting pop up, but you can always share your selection in the chat. Okay, fantastic. So 57% are going for 1 in 20.
1 in 20. No, not bad, not bad. Great. Thanks very much. Yeah. So it's actually 1 in 8. So it's actually even more common than that. Over 75 will have some degree of aortic stenosis. Obviously, not all these patients will have severe aortic stenosis, but they'll have some degree of aortic stenosis. So 1 in 8 of over 75. So again, looking at the demographics, it's going to be something that we're going to have to be increasingly comfortable with and familiar in managing. Just coming back to sort of auscultation, so the best place to listen to the aortic murmur is in the right second intercostal space. And again, just listen to the typical sound of the aortic stenosis. So it's that typical harsh crescendo and then decrescendo type murmur. Aortic stenosis, a little bit like sort of mitral stenosis that we discussed earlier, with a sort of 20 to 40 year sort of latency period. It's a relatively insidious disease. Certainly it's life-threatening in its more severe sort of form, and is primarily related to age-related aortic valve calcification and valve degeneration. Characteristics of aortic stenosis, again, as I mentioned, long latency period, when the patient will be essentially asymptomatic, relatively rapid progression after symptoms appear. And again, I'll cover this in a couple of slides' time, but symptoms are so key when we're seeing patients with aortic stenosis. High mortality in patients who either aren't put forward or can't have intervention for whatever reason. We know the mortality in this group is exceedingly high. And again, I'll illustrate that in a few slides. So typically is normally calcific, so this is the normal tricuspid aortic valve. An issue with mild stenosis, you get a little bit of reduced leaflet excursion with some calcification around the valve annulus. With more moderate aortic stenosis, you get calcification and thickening of the leaflets, with reduced excursion. And in severe aortic stenosis, you get fixed, thickened, calcified leaflets. Again, as you can appreciate, with a significantly reduced effective sort of orifice area for the blood to pass through. Factors increasing the risk of developing aortic stenosis. So advancing age, we're all getting there, and there's really not much we can do about that, but we know that certainly patients over 70, 75 have a very, very high incidence of some form of aortic valve disease. Other things that will accelerate that or sort of potentiate and increase the risk of developing aortic stenosis include those with hypertension, diabetes, and smoking. Again, the sort of pathology and the pathogenesis of aortic stenosis is primarily an inflammatory condition of infecting the leaflets. So it's the same type of risk factors that predispose to developing coronary disease or atherosclerotic disease elsewhere, whether it's peripheral or coronary. Very, very similar risk factors as in aortic stenosis. Other comorbidities, again, will increase the probability of developing aortic valve thickening, calcification, and functional impairment, such as chronic kidney disease and coexisting coronary artery disease. In terms of symptoms, so symptoms may well be, again, just reduced exercise tolerance, reduced stamina, fatigue, shortness of breath, possibly fainting or sort of syncope or pre-syncope. Again, these are sort of more sort of red flag type symptoms that you really do need to be alert to in this sort of situation, or patients who may well develop symptoms of typical angina or palpitations. So the onset of symptoms certainly marks severely reduced survival. So initially there's a latent period, and then once the patient develops symptoms, then there's a very, very rapid increase in risk of morbidity and mortality. And the symptoms that we need to be most mindful of are patients who develop either typical angina symptoms. Their average survival following development of angina on a background of aortic stenosis, approximately 5 years. If they develop syncope, it's about 3 years. And if they develop heart failure, it's about 2 years. So again, very, very significant bearing on life expectancy. And this would be akin to a lot of the more aggressive cancers that we obviously manage and see within sort of primary care setting. And we need to be thinking of aortic stenosis in the same way that we do some of these more sort of aggressive, whether it's breast or lung sort of cancers that and colon sort of cancers. In terms of prognostically, we need to be managing these patients just as proactively. Approximately 50% of untreated patients with severe aortic stenosis will die within 2 years of experiencing symptoms. So symptoms are absolutely key in terms of assessing this cohort of patients, because it has such a big bearing in terms of their prognosis and survival. And we know that patients can be relatively asymptomatic for a long period of time. For patients who we think are asymptomatic, there's always the potential of thinking about a stress test to see if you can unmask those patients who are truly asymptomatic. So if we exercise people with severe aortic stenosis who are asymptomatic, up to a third will develop symptoms during the test, whether that be dyspnea, chest pain, sort of dizziness, or ECG sort of changes. And in this cohort, we know that a watchful waiting approach probably isn't the best strategy for them. They do benefit from early intervention in terms of their valve disease. If they're truly asymptomatic with a good workload on the exercise test, then it's probably reasonable to keep evaluating these patients through a surveillance program every 6 months in terms of assessing not only the functioning of their valve, but more importantly, any change in sort of symptoms, as well as being very, very aggressive in terms of managing their risk factors, whether that be the hypertension, smoking, or other risk factors. So again, just what we see on echo in patients with aortic stenosis. So the top right-hand panel, you've got a very, very thickened, heavily calcified aortic valve. And as you can appreciate, really not much movement there. It's very, very sort of fixed with reduced leaflet excursion. In the bottom left-hand panel, you've got relatively, you've got good LV systolic function, but you've got significant LV hypertrophy in response to trying to sort of pump that blood out through the thicker, narrowed aortic valve. The LV tends to hypertrophy, so you get significant LVH. And in the lower right-hand panel is the Doppler profile of the blood, of the flow through the aortic valve, with significant increase in both gradient and velocity, consistent with severe aortic stenosis. And these are just the measurements that we tend to use in clinic when we're assessing the severity of aortic stenosis. So valve area of less than 1, mean gradient of less than 40, or a velocity of greater than 4 meters per second. In terms of what happens to patients once they've been diagnosed with severe aortic stenosis, most secondary and tertiary centers now have a multidisciplinary or sort of heart team, which is made up of cardiologists, anaesthetists, cardiac surgeons, for them to decide what's the best form of strategy for managing these patients. So very, very rarely now is this decision just undertaken by one sort of cardiologist. It's often referred through to the heart team, because the treatment options are now more varied and a little bit more nuanced than they were sort of 10 or 15 years ago. So just looking at what the treatment options are, and obviously primarily they're sort of surgical options, but as I sort of reiterated earlier, the prognosis and survival for patients who do not have valve replacement is very, very poor indeed. So from time of diagnosis, the vast majority probably would have deceased within about sort of 10 years. We know that aortic valve replacement, whether it's through conventional surgery or through TAVI, improves survival by up to 40%. So it's an incredibly effective and important intervention in this group of patients. It's the only effective treatment for severe aortic stenosis in symptomatic patients. There's absolutely no role for sort of medical therapy aside from just ameliorating symptoms. It's not going to make any difference from a prognostic point of view, but obviously surgery will do. So conventional surgery, again, we're all very, very aware of this, has been around a long time, and lots of procedures are still done. Obviously, there's significant recovery in terms of both in hospital and post-operative recovery, even now with sort of less minimally invasive techniques. They still need a long time to recuperate. And interestingly, probably 1 in 5 patients are deemed not fit to undergo conventional surgical aortic valve replacement due to their high surgical risk. So this brings us on to transcatheter aortic valve implantation, which has been around for about 15 years now. And really this was, oh, sorry, there's another poll. I don't probably expect you to know, but would anyone have a guess as to how many TAVI sort of implantation sites there are in terms of access points? Or I can just go through it very quickly if you want. Hello?
Thank you. That's live on the screen. Have a little go, bit of fun. How many transcatheter aortic valve implantation access points are there for the minimally invasive? 1, 2, 4, or 5? I'll give you another 10 seconds if you haven't yet cast your vote. It's be interesting. Chance for Chris to have a sip of water and take a breath. You've done really well, Chris. It's a lot to get through.
How am I doing for time-wise? How are we doing?
Okay, we're 7:23, and the option number 2. So the answer B with 2 possible ports has got the most answers. Okay.
Oh, well done. Thanks very much. Yeah, sorry about that. It's a bit of a sort of trick question. There's no idea why you should know, really. Anyway, apparently they're 4 access routes. So there's transfemoral. So this is actually the commonest route, and certainly the one locally that our sort of interventionalists tend to prefer. There's a transapical route, which tends to be done by the surgeon, certainly in our local centre in Southampton, that's done by the surgeon. So these are probably the 2 commonest access routes for TAVI. Transaortic, or the other one is transsubclavian. So all of these are to access the sort of left side of the heart, i.e. they can get direct access through to the aortic valve. But as I mentioned, I think the vast majority of patients, if you're counselling them and sort of talking to them about the procedure, the majority probably will be either transfemoral or transapical. So it's most commonly performed by sort of femoral access. And just a sort of quick guide as to what actually happens. So obviously the valve, relatively big catheter, certainly bigger than your sort of standard angio catheters, is fed up through the femoral artery, so it accesses the arterial system to get into the left side of the heart. The compressed valve, which is on the end of the catheter tip, is tracked through the femoral artery. The valve's actually positioned over the native calcified aortic sort of stenotic valve, so it's positioned there, and again they use X-ray and contrast to make sure it's absolutely in the right spot. The TAVI valve is then expanded within the native valve, so obviously the native valve stays there, it's compressed against the side of the aortic annulus, and the TAVI valve is expanded with a balloon within that, and there's a sort of mesh and network within the valve itself that then locks itself into position. So once it's been expanded, it then locks into that position. The sizing and the workup of these patients is very, very critical in terms of making sure that you get the right size valve so that it sits comfortably within that sort of aortic annulus. Once it's been deployed, the balloon is then deflated and the catheter withdrawn, and obviously you're left there with the TAVI valve in situ. So it all looks very, very simple and straightforward. In terms of patients, we've mentioned earlier about the sort of 20% of patients who are often not considered fit enough to undergo conventional sort of open surgical AVR. So again, a lot of these patients, again, will be very familiar. They may have other comorbidities, be elderly, frail, hypertension. They may have sort of morphological criteria, which mean that sort of intervention is from a surgical point of view, is going to be very high risk, such as prior sort of chest radiation, where they get a lot of scarring and sort of tissue around the aorta, previous stroke, or if they've got a heavily calcified or sort of porcelain aorta, then again, surgical options may well not be appropriate. So for a lot of these patients, then we're now thinking that TAVI is an option for these patients, rather than necessarily just condemning them to what is obviously a incredibly poor prognosis without intervention, as we saw earlier. TAVI offers many benefits to patients with aortic stenosis. It's both short and long-term relief of symptoms, as well as improving life expectancy. So this isn't just about ameliorating symptoms and improving quality of life. This is also about keeping patients alive longer. Certainly it's less invasive than conventional open procedures, much shorter procedure, far less pain, patients much shorter stay in hospital. Our average locally in Southampton is about 2 to 3 days, and then they're out in hospital, and much shortened recovery time compared to conventional valve replacement. Looking at the latest sort of ESC guidance, which is probably the best one, contemporary one to hand, certainly they've suggested that TAVI should be recommended in all patients who are not suitable for surgical aortic valve replacement, as assessed by the heart team. For patients with low surgical risk, again, conventional surgery probably is the treatment of choice. And certainly low risk or even intermediate risk patients should be offered conventional surgery. But actually there's now a lot of evidence with some of the newer TAVI valves that actually their durability and longevity is very, very good indeed. So, and the evidence even in intermediate risk groups now is showing that their TAVI is just as effective as surgical valve replacement. So the ESC have now expanded the indications for transcatheter valves because there's new evidence in this intermediate risk population. So I think we are going to be seeing a lot more of our patients having TAVI than would previously have been the case if it was just restricted to that high risk, sort of 10 or 20% of patients. And just lastly, just to sort of wrap up, just going through a sort of patient that we had locally a couple of years ago, just sort of typical sort of scenario, sort of 84-year-old presenting with exertional breathlessness on a background of heart failure, orthopnea and PND with 2 admissions, previous revascularization with CABG, and had then subsequently had a PCI, and also comorbidities include hypertension. Echo showed good LV function, mild LVH, as we saw on the previous echo, with severe aortic stenosis. She proceeded to have coronary angiography just to look at the patency of her grafts. Because obviously you always need to think about whether these patients will need some other intervention at the time of valve replacement because of the increasing prevalence of coronary disease. They may well need revascularization, which will have a bearing in terms of which strategy is favoured for an individual patient. Given her age and comorbidities, her mortality risk at surgery using one of the calculators was over 10%. So in this case, it was felt that that risk was too high and that TAVI would be the appropriate intervention. So again, just looking at the TAVI, this is actually obviously what you see in the cath lab. So the TAVI is around the balloon before it's inflated and just being placed in the aortic annulus, and then it's dilated, and again there you can see the balloon, and the actual valve is dilated around the balloon before the balloon then deflates and the catheter is withdrawn. So in summary, we really need to be more vigilant and I think proactive around valvular heart disease, thinking about symptoms of patients presenting, just wondering, could this be related to valve disease? We need to be comfortable and confident around auscultation. We're doing a lot more work in terms of identifying atrial fibrillation, being more proactive in terms of pulse checking, and exactly the same principle applies, I think, to valvular heart disease. We really need to make sure we're listening as often as we can, and don't just do it ourselves. And let's encourage our sort of nursing colleagues to do it, because they see a lot of these patients in their clinic, in the asthma clinics, in the COPD clinics, in the flu clinics potentially. So I think just listening, if you think there's a murmur there, I would get an echo. I wouldn't be too fussed about trying to sort of characterize it or nuance in that sense, but particularly if the patient's got symptoms which may be attributable to valve disease, I would just think about getting an echo. So listen, suspect, so particularly obviously in aortic stenosis, typical systolic murmur, and refer. So refer, open access echo, then you've got your answer. Obviously, depending on that, you might need to sort of take it further in terms of sort of formal referral. So in summary, heart valve disease, there's a lot of it about. Increasing prevalence driven primarily by aging population and sort of natural valve degeneration. But we've seen there are other risk factors, whether it's inherited aortopathies, cardiomyopathies, rheumatic fever, again, in sort of particularly elderly patients or those who maybe are living in areas where it's more endemic. So there are other drivers for it, but primarily it's driven by the demographics and increasing aging population. We must be aware of symptoms. It's really, really important. We just don't sort of attribute those to sort of growing old, and that's just part and parcel of it. There may well be something underlying it that is amenable to intervention around sort of valve disease. So auscultation is absolutely essential, and I can't reiterate that enough. Echocardiography, I'm afraid, is still going to be the key examination in terms of sort of first point of call, in terms of assessing the LV and the valves. Refer patients for assessment if they've got severe lesions, whatever they be. They do warrant assessment through the cardiology, who may well be working in partnership with the local cardiothoracic and heart team. And interventions are helpful not just for symptoms in terms of quality of life, but even more importantly around prognosis and keeping patients alive longer. So just in summary, contact details for Heart Valve Voice. So there's a lot of information. So again, if you want to sort of signpost patients with valve disease, or you want information yourself, then do look at Heart Valve Voice. Again, I mean, there's lots of other resources, and the British Heart Foundation are excellent, but Heart Valve Voice do have a lot of information. So again, if you just want to give your advice, your patients some advice, or signpost them, then do use Heart Valve Voice. Again, this is very much a sort of patient-focused charity. So if they just want to talk to other patients who've been through similar experiences, again, they'll get a lot of support there. And I think that's it.
Okay.
Thanks.
Fantastic. Thank you so much, Chris.
No, pleasure. Yeah.
Are you okay for a couple of questions?
Yeah, no, absolutely. Yeah.
So just before I go through some questions, I have shared a link for the post-webinar survey, so I would encourage all to click that. It'll open in your web browser, and also a link there to get a PDF of the slides from this evening that you can download and share with colleagues or use for your own.
Yeah, no, please do. Absolutely. Yeah.
So share it far and wide, but please do complete the survey. It's very valuable for Heart Valve Voice, and in particular for our presenters. We collate and anonymize your feedback. It's a very short survey, and obviously when we collate and anonymize your feedback and then share that with the presenter and Heart Valve Voice, who have made this session possible. And you'll be automatically redirected at the end of the survey to download your CPD certificate. So look for the links there in the chat. So a question, let's see, Ron, are Corrigan's sign and Quink's sign worth looking for?
Ooh, good question. No.
I don't know. I've got no idea what Ron's talking about.
It's not something maybe I have inadvertently, but
Ron's keen. Don't worry, Ron. About
absolutely, no, there you go. I'm sure they are.
And then another question: is it beneficial to treat these patients with the there's been in the media polypills?
Yeah, good question. I mean, a lot of these patients will have concomitant atherosclerotic disease and risk factors or hypertension, and so in that sense, absolutely optimally managing those risk factors is important. Again, I think the polypill is probably not intense enough in this population, because this is really a sort of secondary prevention population. As far as I'm aware, the polypill is more around sort of upstream, sort of primary prevention. So these patients, you're going to be managing them pretty intensively in terms of their hypertension and their lipids, and potentially even antiplatelets if they've got coexistent sort of coronary disease or previous revascularization. So
great stuff. Olu's asking, does BNP, natriuretic peptide, BNP, does that test have a role in diagnosis?
I mean, it's a really good question. Yeah, I mean, I use BNP quite a bit. I mean, not in this setting, but in patients who have breathlessness. Obviously, primarily as indication, is there some form of LV dysfunction, whether it be systolic or diastolic? A lot of patients with significant valve disease will have LV dysfunction, so undoubtedly their BNP will be raised. So no, I think it's a really good question, and absolutely, I think I see BNP in many ways almost as a sort of almost like a ticket to echo. Certainly locally, it's part of our sort of heart failure pathway, and if they got a high BNP, they get into that 2-week system and they get an echo and they see a cardiologist. So, we mustn't forget, the morbidity and mortality, the prognosis for these patients is really, really poor. So I'm really pleased that, we are managing them akin to some of the sort of cancer pathways. And BNP, if that's a way of getting an echo, then that's absolutely fine. Yeah, I don't have a big issue with that. But,
fantastic. Some positive feedback. Ron saying, great talk, especially
BNP. If you just hear an echo, if you just hear a murmur, and you just want to sort of clarify what's causing the murmur. And so I mean, the symptoms should determine whether or not you get BNP. So are you suspecting they've got a degree of LV impairment? So that should still be the rationale for using BNP.
Okay, good. Sorry, I cut you off there.
No, sorry. Yeah.
So yeah, BNP really valuable for helping assist you with your suspicion of heart failure, but not reliable with atrial fibrillation.
No, it's very, very high. It'll always be high in AF. So you could argue whether or not you need a BNP.
Okay, great. I'd just like to give you some really positive feedback. So Ron says, great talk, especially the auscultation sounds. Many thanks.
That's a pleasure.
Ella saying thank you, and Wendy, thoroughly enjoyed the talk. The auscultation review especially helpful.
Great.
And colleagues, remember you can listen back to the recording and find those key bits if you want to. Please do share your link that we'll send out. You'll get a link to the recording in an email tomorrow. Feel free to share that with your colleagues if you're doing in-practice, in-house trainings. It's a really valuable session. And
no, I agree, and with your nursing colleagues as well, because don't forget, nurses are going to be doing a lot of the auscultation and the checks, and your advanced nurse practitioners, because I recognise that primary care now we're working with lots of different disciplines and colleagues, and I think all of us really need to be aware of the importance of valve disease, because we may well have the opportunity to pick it up. They do share it widely. Absolutely.
Yes, and I think that point about seeing if we can be opportunistic, how creative can we be, just having a listen. It doesn't take long at all, as Chris has demonstrated and sort of reminded us. Have a little listen, get in the habit, I think, because I think if I'm honest again, I'd fallen out of the habit of just automatically listening to heart sounds, and having heard the first session last year on this topic, I'm much more likely to have a little listen. So it's helped my habit. So thank you for that, Chris.
No, pleasure.
Thank you to Heart Valve Voice. Thank you everybody who submitted questions and everybody who took part in the poll questions. Look out for the email tomorrow with the reminder of the survey link and the download link for your study guide PDF and a recording link. Please do share as widely as you can. Thank you everybody for your time. Thank you so much, Chris.
Great. Thanks very much, Simon. Thanks everyone. Thank you.
Bye-bye.
Cheers.